Hi, everyone, and thanks for joining us today. We're Group 15, and we're excited to share a proposal for an AI enabled rehabilitation system that uses nothing more than a smartphone camera to assess movement and support musculoskeletal recovery. Let's start with the clinical problem. Musculoskeletal disorders are one of the world's major health burdens. They significantly increase disability adjusted life years and negatively impact the global economy due to pain and mobility impairments that can cause things like lost workdays. Physiotherapy is a standard of care for improving mobility and reducing chronic pain associated with musculoskeletal disorders, but access is a persistent challenge. Geography, long wait lists, cost, and transportation barriers make regular in person therapy difficult to access. Home based physiotherapy is a promising alternative, but adherence is proven to be mediocre, and exercise quality is often worse, which negatively impacts treatment outcomes. So, without supervision or feedback, patients repeat the same mistakes, plateau in progress, and sometimes even make their symptoms worse. So, a big challenge then presents itself. How can we bring expert level supervision into the home without wearables, sensors, or expensive equipment to create an accessible and effective home based physiotherapy system? Our solution is a three-part AI pipeline designed to replicate that physiotherapist is watching you exercise kind of experience. First, a lightweight CNN extracts movement features from a standard smartphone video. These are things like joint positions, limb angles, and posture. Second, those features go into an unsupervised autoencoder trained only on the correct technique for a single exercise. On our pilot, this is going to be the squat. By learning what normal looks like, it can recognize deviations through reconstruction error. If the model can't accurately reconstruct a movement, that signals that something is off. Things like asymmetry, shallow depth, excessive trunk lean, and so on. Third, a large language model translates those deviations into natural language feedback. For patients, it gives them simple, actionable cues, things like keep your knees outward or keep your torso more upright. For physiotherapists, it generates structured summaries on adherence, deviation patterns, and progress trends. The pipeline works like this: the patient records a short squat video, the CNN extracts the features, the autoencoder flags anomalies, and the LLM produces feedback and clinic ready documentation. To train this system, we propose a training set of around 450 correct squat samples from 30 supervised participants, recorded from both frontal and lateral views. These samples form the statistical baseline of normal movement. We'll also have a testing set of about 150 samples, mixing correct and incorrect squats. Experts are going to label these for validation so we can evaluate accuracy and recall across reconstruction error thresholds. We test both accuracy and recall because accuracy measures the overall correctness of the predictions, while recall focuses on ensuring all critical positive cases are identified. For patients, a standardized recording protocol is critical. We need frontal and lateral views. We need the videos to be 15 to 20 seconds long and to be performed for 3 to 5 continuous repetitions. This is going to capture the full movement cycle and compensate for any fatigue related issues.
Our implementation plan starts by narrowing the system to one exercise so we can build a reliable prototype before expanding to additional movements. Then we define our objective: improving accessibility, exercise accuracy, and clinician monitoring. Finally, we identify direct stakeholders, which are patients and physiotherapists, as well as other stakeholders such as supporting staff, and interview them to understand needs and workflow fit. We then need to assess implementation factors. Um, including contextual factors like staff readiness for a change, whether the hospital has a culture of being open to new innovations, and the degree of interdepartment collaborations in the hospital. But also technical factors, including data security, software and hardware feasibility, and storage requirements. Finally, we develop education modules to address the concerns found in the interviews and our assessments. Staff will be taught how to interpret AI outputs, monitor patients, and integrate the tool into clinical workflows. Patients will be taught how to position their phone, optimize lighting, and follow recording instructions so the system can do its job effectively. For our evaluation strategy, we use a mixed methods approach. From patients, we collect two kinds of feedback: intra exercise, which captures their immediate reaction to the clarity and usefulness of the AI's real time guidance, and post exercise, where they reflect on overall strengths, limitations, and suggestions after completing the session. From physiotherapists, we look at both quantitative outcomes like pain reduction, functional improvement, and adherence, and qualitative feedback, focusing on workflow fit and how the tool compares to options like sensors or in person only care. Our system offers key strengths. First, the unsupervised autoencoder removes the need for large labeled error datasets, making model development far more feasible in real settings. Second, the large language model provides personalized, easy to understand coaching cues that meaningfully improve exercise quality and patient compliance. Third, relying only on a smartphone camera maximizes accessibility and reduces barriers to care. And finally, automated clinical reporting gives physiotherapists continuous objective insight into home exercise performance. But there are also important limitations. Raw RGB videos carry significant privacy risks without strong protections. Large language model hallucination could produce inaccurate or unsafe feedback without added guardrails. And autoencoders detect anomalies, but should also specify which biomechanical error occurred. And generalizability may be limited across different body types, environments, and devices unless trained on a more diverse data. For our projected clinical impact, this system will deliver better exercise accuracy by giving real time feedback that corrects form and reduces compensations. It will support early detection of movement risk by flagging subtle deviations that may lead to re injury. It will create a lower system burden through better adherence and fewer unnecessary visits. And we expect improved access to care since high quality guidance can be delivered through any smartphone. And finally, it will provide objective monitoring for clinicians with continuous standardized data between appointments. Overall, the model will strengthen outcomes, accessibility, and efficiency in MSK rehabilitation. Thank you for your attention.